Accessible information on self-directed support. Report summary. Introduction and background. This report contains the findings from a consultation carried out by the Health and Social Care Alliance Scotland, the Alliance, for the Scottish Government, to inform the implementation of the Self-Directed Support Improvement Plan 2023 to 2027. The full report is available on the Alliance website. The Alliance were asked by the Scottish Government to support this consultation. From December 2023 to February 2024, the Alliance carried out a small-scale mixed methods research project, a national online survey, focus groups, and one-to-one interviews. The engagement covered people's experiences of accessible information around SDS, and reflections on what works well, what does not work well, and what needs to change. We received information from 56 people's experiences of accessible information around SDS and social care. This report summary contains reflections and recommendations from the Alliance for potential areas of action. Introduction to self-directed support. Self-directed support is Scotland's approach to social care. The associated SDS Implementation Plan 2023 to 2027 recognises that adults, carers, including young carers, children and families who need social care support have the right to choose how that support is delivered in order to lead full lives and live as equal citizens. SDS is underpinned by the fundamental principles of choice and control, and the human rights principles of equality, non-discrimination, participation and inclusion. People should have choice and control over how to use their SDS. For example, they could decide to use it to support their right to independent living, through help with personal care in the home, equipment, or temporary adaptations. People can also choose to use SDS to enjoy their rights outside the home. For example, to attend college, go to work, participate in leisure pursuits, or take short breaks. People should also be able to choose between using SDS budgets to buy support from a local authority, private or third sector service provider, or by employing personal assistants, or a combination. Local authorities have a legal duty to offer people who are eligible for social care a range of 4 SDS options. These are Option 1, a direct payment to the individual who can use it in any way they choose, as long as it secures the outcomes agreed between the person and their social worker, as set out in their support plan. Option 2, when an individual chooses their support and provider, but the local authority or a local organisation maintains control of the budget. Option 3, when the budget and support is managed and provided by the local authority in coordination with the individual. Option 4, a mix of some or all of the first 3 options. The principles of choice and control apply irrespective of which option is taken. Consultation findings. A key theme in opening discussions and responses was participants' uncertainty about SDS and social care. One participant shared the following statement, which was repeated by several other people. I didn't realise there were 4 options until the research team member read them out today. Participants' uncertainty about SDS suggests that there needs to be more accessible information about SDS that is easily available in the public domain. There is also a role for professionals to be educated in and signpost people to SDS, and specifically to accessible information about it. It's important to ensure that relevant health and social care professionals with whom they're likely to come in contact, for example GPs, audiologists, opticians, ophthalmologists, rehabilitation and habilitation workers, as well as social workers and occupational therapists, are able to signpost people to accessible information on SDS. Similarly, social care and support providers, third and independent sector organisations, independent advocacy organisations, and independent advice and support organisations have a role to play in signposting people to accessible information on SDS. People highlighted that where communication support was provided and included in their SDS packages, it had a significant positive impact on their daily lives. Case studies could be usefully included in social work professionals' training and guidance to demonstrate possible examples of SDS provision for people with sensory care requirements. Accessible information about SDS. Over a fifth of survey respondents indicated that they always or usually received information about SDS and social care in a format that was accessible to them when they needed it. Another 22 reported that they sometimes received accessible information. However, 40% of respondents indicated that they rarely or never received accessible information about SDS. A further 13% of participants stated that they were unsure. These results indicate a need for further work to improve accessible information within social care. People who recounted positive experiences highlighted the role of the third sector in the provision of good quality accessible information and of support from their HSCP to arrange BSL interpretation. Inclusive communication takes time, money and resources to do well. If the third sector, and specifically sensory sector organisations, are to continue providing high quality information and support for people, they need to be provided with adequate and sustainable resources to provide good quality accessible information and support. In terms of potential improvements, while third sector organisations were held up as examples of good practice, people tended to reference specific sensory sector organisations. People recommended work to improve both the information that the sensory sector organisations hold on SDS and social care, to effectively signpost people to sources of advice and support, and work to improve the sensory awareness of SDS advice and support organisations. Within the references to local authority and HSCP provision of accessible information on SDS and social care, the good practice examples around BSL interpretation were welcome. However, even in those instances, people recounted issues with internet connectivity and the availability of interpreters, which resulted in delays to appointments and assessments. More needs to be done to streamline the process and reduce the delays. that people who are deaf, deafblind, or who have visual impairments face around inclusive communication. This includes the training and provision of more interpreters and electronic note takers, and better training for staff across HCPCs and local authorities in sensory awareness, and the processes for requesting support with accessible information, such as ordering Braille text or booking a BSL interpreter. In many of the examples shared by participants, people described situations where HSCP and local authority employees wanted to be able to provide accessible information to people, but were stymied by inaccessible and inflexible systems. Examples include a bar on social workers sharing information with participants by email or text, even when electronic information was needed for participants who used screen readers. A more flexible and accessible approach to systems design and worker autonomy is needed to provide high-quality, accessible information and to comply with the Equality Act 2010. Information on the 4 options. Nearly a fifth of survey respondents indicated that they had received accessible information about all 4 options. 15% reported that they received accessible information about some of the options. Nearly half of participants indicated they did not receive accessible information about the 4 options. A further 19% of participants stated they were unsure. Most people had either received partial or no information on the 4 options of SDS. One participant shared the following experience. "We really just got told what would be the best option for us. I don't think anyone went into the 4 options, no. We were just told what to go for." These findings are in keeping with the existing evidence base on people's understanding of the 4 options. It is also clear from participants' responses that there is a lower rate of understanding and information about the 4 options amongst people who are deaf, deafblind, or who have a visual impairment, compared with the wider population of people who access or wish to access SDS. That nearly half of participants indicated they did not receive accessible information about the 4 options, with a minority receiving accessible information about all 4 options, indicates that this population group is receiving unusually poor quality information. This is likely to impact on meaningful choice and control of SDS options, as well as basic access to and uptake of SDS. This is not an observation intended to critique overworked social workers. However, this pattern highlights a need for widespread provision of accessible information on all 4 options of SDS, in multiple formats, possibly via a national platform that can then be used and signposted by people working across different local authorities. There is also a role for professionals to be educated in and signpost people to this information. Good practice in accessible information on SDS. Overall, most people recounted more positive experiences obtaining accessible information when there was an established relationship with a particular person or organisation. For example, a named social worker or specific third sector organisation. Deaf BSL users spoke positively about the impact of Contact Scotland BSL and of being able to arrange remote BSL interpretation with relative ease via that platform. People also highlighted the importance of assistive technology and the ease with which well-designed digital information could be accessed via screen readers. These findings suggest that existing work to improve digital inclusion should be sustainably supported, resourced and expanded in areas where such services are not available. These actions would enable more people to have the choice of accessing digital and assistive technology and to seek help and further information if required. People also discussed good practice examples of accessible information around social care. More broadly, not just information shared by social workers during an assessment. Although this was acknowledged as important, but the incidental information that hearing or sighted people acquire through day-to-day life via advertising, or what one deaf BSL user referred to as conversations overheard on the bus. Participants particularly welcomed organisations who demonstrated vibrant and dynamic social media use and regular e-bulletins, as this served to meet some of that information demand, as well as providing information that was presented in interesting and engaging ways. If Scotland were to develop a national accessible information platform for social care and SDS, we suggest that the launch should be accompanied by a national publicity campaign to ensure that the information is spread widely. Poor practice in accessible information on SDS. There was widespread agreement that SDS is not publicised enough for people who are deaf, deafblind, or who have a visual impairment. More needs to be done on introducing SDS in accessible formats, specifically on how it can be used by people who have sensory care requirements. People highlighted the need for improved and flexible communication with social work and the adverse impact of out-of-date information. The latter is particularly acute for people who are deaf, deafblind, or who have a visual impairment. Travel can be expensive and challenging, and so when advertised events and support sessions are no longer running, they experience a double frustration, having made a fruitless journey. These findings suggest the need for public bodies to implement regular audits of the accessible information that they provide on services and support to ensure that information remains current. People who were unhappy with decisions around their SDS assessments relayed that information around complaint systems was not automatically available in accessible formats. The provision of upfront accessible information on complaint systems should be standard practice across Scotland to reduce the burden on people who are challenging decisions, possibly without communication support if they have been refused access to SDS. Participants also reflected on the time that requesting accessible information added to any queries or requests for support. As much information as possible should be provided in accessible formats from the outset. This action would alleviate some of the health inequalities faced by people who are deaf, deafblind, and who have visual impairments, through reducing some of the additional waiting time. Finally, people also reflected on the need for services to consider multiple forms of communication support, including for people who are deafblind and people who have autism or a learning disability alongside deafness, deafblindness, or a visual impairment. Improving accessible information on SDS. Given the varied provision of accessible information, a range of participants were strongly in favour of a centralised approach to accessible information on SDS. They recommended that this could include information that remains consistent across different local authorities, what SDS is, who is it for, how to request an assessment, and examples of how it can be used, especially as that pertains to communication support. People also wanted to have more consistent information about assessment processes and eligibility criteria, but that may need to be developed at a more local level given the current variance of eligibility criteria across Scotland. People recommended greater involvement of lived experience and disabled people's organisations, centred on sensory, in design and testing for accessibility. This includes basic accessible information provision, in print, online, via the telephone, but also apps and technology used to deliver SDS, for example, prepayment card apps for submitting Option 1 receipts. People also highlighted the role of community groups, for example deaf clubs, in sharing information about services and support, and the importance of engaging with those groups. Participants stressed the need for better sensory awareness among social workers, including fluency in BSL and understanding and use of BSL relay interpretation when appropriate. Deaf BSL users suggested that local authorities and HSCPs could employ BSL officers, and more deaf BSL users generally, to better support social workers in assessing and supporting deaf people to access services. People also recommended that a digital choice approach should be taken for all systems design around accessible information. While many spoke positively of assistive technology and digital accessibility, for example the online provision of deaf relay interpretation for people in rural areas, they also raised concerns about the possible exclusion of people who are not confident in using technology or who have poor connectivity if they live in a rural area. Participants discussed the benefits of a single point of contact and recommended that this be implemented wherever possible to enable queries to be responded to promptly. This recommendation was linked to comments on the need to be able to contact social work and associated services, including care providers, via a variety of formats, to enable people to pick the option that best suits their access requirements. Listed options included email, telephone, texts, WhatsApp, online forms, digital meeting platforms, print letters, and face-to-face communication, and the provision of communication support professionals on request. By providing a variety of means by which to contact social work, local authorities can ensure a system is accessible via one format or another to everyone for equal access to information, support and services. One participant summarised this position as follows: everyone should be equal. Everyone has the right to SDS. It's important to have these options and for that to be communicated. Waiting times for accessible information. Responses to questions around waiting times were polarised. People either had very positive experiences with prompt provision of accessible information and BSL within a week, month, or reported never receiving information in a suitable format or only after repeat requests. Generally, people who requested a BSL interpreter reported relatively prompt responses, within a week or a month, although that still entailed a longer wait than people who do not require language support professionals. People who are not BSL users generally reported longer wait times for accessible information. Participants also reported having to instruct people on how to meet their communication requirements, which they concluded indicated a low level of sensory awareness training within their area. They also highlighted the need for information to be available in digital formats, particularly for people using screen readers. Participants recommended that waiting times could be reduced by better staff training in how to meet accessible information requests and the need for sensory awareness and inclusive communication training more generally. Impact of accessible information. Accessible information and inclusive communication is vital to people's ability to participate in their community and have equal access to services and support. Appropriate, tailored communication and accessible information makes a significant difference to people. One participant shared that it ensured I was at the centre of my care and decisions. By the same measure, when people did not receive accessible information, they reported a range of negative impacts. Phrases like let down, stressful, not included, and ignored were common amongst those who had experienced poor or no provision of accessible information. These experiences highlight the need to improve public and private sector provision and understanding of accessible information and inclusive communication, outlining and confirming why they matter, who is responsible for provision, how to meet people's communication requirements, and how to evaluate success. Social workers' understanding of accessible information. Nearly a quarter of respondents from the social care professionals always, or usually, know how to meet their accessible information requirements. A fifth indicated that social care professionals sometimes know how to meet their accessible information needs. Over a third of participants stated that social care professionals rarely or never know how to meet their accessible information requirements. A further 20% of respondents were unsure. These findings indicate that more work is needed to support social work professionals in how to provide accessible information, including ensuring smooth and prompt internal systems for processing such requests. Participants noted that the limited provision of accessible information was not down to individual social workers' willingness to provide information, but the lack of appropriate accessible formats still adversely affected their ability to understand and make informed decisions. A more flexible and accessible approach to systems design and worker autonomy is needed to provide high-quality accessible information. People discussed the need to allow more time for assessments and communication with people who are deaf, deafblind, or who have visual impairments. A recurring theme was that people felt that communication with social workers was often rushed, which, while a common concern among the profession and for people accessing SDS, is a particularly acute concern for people who require more time to access information. due to the additional time needed for translation between English and sign language, and other comparable communication requirements, including participants who have both a learning disability and sensory care requirements. The accommodation of extra communication time should be built into caseload planning and timings. People also suggested that there could be better communication within health and social care professionals. For example, information sharing between ophthalmology, audiology, and social care to meet people's accessible information requirements. Finally, participants stressed again the need for widespread and high-quality sensory awareness and inclusive communication training for social workers, but also for public sector employees more generally. Care workers' understanding of accessible information. As with social work professionals' understanding of accessible information, participants reported that the people who provided care typically did not understand how to meet their accessible information requirements. Only 12% of respondents found that people providing social care and support always or usually know how to meet their accessible information requirements. A quarter indicated that care workers sometimes know how to meet their accessible information needs. Over a third of participants stated that care workers rarely or never know how to meet their accessible information requirements. A further 25% of respondents were unsure. As with the discussion on social workers, participants noted that the limited provision of accessible information was not down to individual care workers' willingness to provide information. They reflected that the poor overall understanding of accessible information was due to limited training provision and high staff turnover. Across the piece, participants reported that there were examples of good practice from care workers and willingness to learn. They also reflected that in their experience, good inclusive communication practice by care workers stemmed either from experience and self-taught good practice, developed by working with and supporting people with sensory care requirements, or from being taught by the person that they supported the best way to communicate with them. Both approaches are valid methods of improving practice. However, people also suggested that more widespread and high-quality sensory awareness and inclusive communication training would help ensure the consistent provision of accessible information and inclusive communication among care workers. One survey respondent shared the following: I feel like having more training for staff on accessible information and support may be beneficial. Sometimes they do not know exactly how to support if they do not have experience. Additional findings. Participants suggested that a definition of deafblindness would improve their ability to access services and support, and specifically to improve consistency of accessible information provision across different local authorities. Deaf BSL users also discussed the need for greater consistency, particularly with regards to language and signing around SDS and social care. They highlighted a range of specific linguistic concerns about how SDS is framed within BSL and potential unintended side effects of specific signing choices, which, for example, could lead to deaf BSL users thinking that SDS only applies to older people or to people with physical disabilities. They recommended that more work should be done to ensure that the language used to advertise and inform people about SDS should be developed by deaf BSL users, including involvement of deaf BSL users from the outset in the development of any new policies and practices to ensure good communication. People also reflected on the importance of education in enabling people to access information. This was of particular concern to the deaf BSL users who participated in the project. People's ability to engage with information via BSL is dictated by their level of linguistic competence. As such, high-quality provision of BSL instruction, particularly in early years, is an essential part of the provision of accessible information and equal access to services and support. Contact. If you have any questions about this project, please contact Hannah Tweed, Scottish Sensory Hub Manager. Scottish Sensory Hub email address is sensory@alliance-scotland.org.uk. The telephone number is 0141 404 0231.